Pneumonia is a lung infection where alveoli inside your lungs are filled with fluid. It is caused by virus, bacteria, and fungi. According to CDC, COVID-19 pneumonia, along with other diseases such as cardiomyopathy and arrhythmia, are categorized under severe COVID-19 diseases that require hospitalization for management. First, how does a person get infected with this disease? Respiratory droplets containing coronavirus enter the upper respiratory tract. The virus infiltrates the respiratory system by multiplying themselves, and thus the infections spread out to the lungs. The infection leads to the activation of inflammatory cells, specifically CD4 lymphocytes, transformed to T helper 1 cells. Activated inflammatory cells, which consist of T helper 1 and macrophages, enters the pulmonary circulation and induce a cytokine storm that leads to rapid, widespread damage of the pulmonary epithelium and alveolar cells, as well as other vital organs. Gases exchange inside the lungs is disrupted due to fluid and dead cell buildup inside the lungs due to this infection. Coughing and shortness of breath are common effects of this disease. Those who suffer from COVID-19 pneumonia can develop acute respiratory distress syndrome, which makes them difficult to breathe and mechanical ventilation is required. COVID-19 pneumonia diagnosis is carried out through chest imaging. A chest imaging can be done in 3 ways, which are chest radiography, chest computed tomography, and lung ultrasonography, based on recommendations set by the World Health Organization. For chest radiography, the abnormalities of the heart, syndrome, lungs, diaphragm, and ribs need to be identified. Generally, looking for evidence of ground glass opacity, peripheral linear opacity, or consolidation in the lung is way to locate these abnormalities. Imaging findings should be used with clinical findings to form an overall assessment. For chest CT scan, COVID-19 pneumonia is identified based on imaging classification and CT features. Similar to chest radiography, abnormalities such as ground glass opacity and consolidation are present in CT image. Lung ultrasonography is used in correlation with high-resolution CT scan of the chest using real-time fusion technique with a curved transducer. Ultrasound findings, including pleural thickening and consolidation of the lung in side-by-side mode, are detected. According to Calabrese et al. In the article entitled Radiotherapy Treatment of Human Inflammatory Diseases and Conditions, Optimal Dose, a radiotherapy dose ranging between 0.3 gray to 1.1 gray is likely to produce an anti-inflammatory phenotype that can reduce inflammation and pain as well as promote healing. Considering the available evidence and the proposed mechanism of action of low-dose radiotherapy, the authors also recommend that a single total dose of 0.3 to 0.5 gray would be beneficial for COVID-19 patients that present with cytokine storm. This dose can be administered to the chest region using both anterior and posterior field, with 50% of total dose administered in each field. This targeted low dose of radiotherapy appears to be most benefit in acute phase of illness when cytokine surge occurs and reduces the possibility of any immediate or long-term adverse effect considerably. As for now, low-dose radiotherapy for COVID-19 pneumonia is still currently tested on clinical trials. There are few studies related to low dose for COVID-19 pneumonia. A pilot study made by Sharma et al. Reported that 9 out of 10 patients had complete clinical recovery without showing acute radiation toxicity after undergoing low-dose radiotherapy treatment. This treatment is done using linear accelerator with prescribed dose of 70 centigrade at the midpoint of anterior to posterior chest separation using 6 MV X-ray photons. A pilot clinical trial carried out by Ahmad et al. Had reported that a single fraction of 0.5 gray was delivered to the whole lungs using linear accelerator with 80 MV photon beams to the participant between 60 and 84 years old. With a response rate of 80%, this treatment had an encouraging result in oxygen-dependent patients with COVID-19 pneumonia. Furthermore, a clinical trial is done by Clayton et al. Has reported that 5 out of 9 patients were treated with whole lung radiation and observed for 7 days. The analysis showed that low-dose whole lung radiation led to rapid improvement in clinical status, encephalopathy, and radiographic consolidation without acute toxicity. There are potential benefits of using low-dose radiotherapy for COVID-19 pneumonia. Firstly, the portability of X-ray machine in hospital allow researchers able to deliver low-dose radiotherapy without difficulty anywhere, such as in isolation room or in ICU unit for patients on ventilators. Next, the X-ray machine are readily available in most of the clinical settings compared to vaccine and pharmacological treatment that are dependent on stock production and distribution from manufacturers. In conclusion, despite low-dose radiotherapy for COVID-19 pneumonia is still on a clinical trial, this treatment has a potential on counteracting this disease. Having more than one weapon in the treatment arsenal may be the best approach for the treatment of patients with life-threatening side effects from COVID-19 pneumonia.